Sir, screen option kanda oru box inagathe oru square box inagathe oru arrow mark underneath താഴെയാവും. I think sir mute ആണോ?
Mute അല്ലല്ലോ, കേൾക്കുന്നില്ലേ?
ഇപ്പൊ കേൾക്കുന്നുണ്ട് sir.
Picture in picture. Screen വന്നാലേ ഇത് കിട്ടുള്ളൂ. ഞാൻ PPT അങ്ങോട്ട് അയച്ചു തരാം.
Okay sir.
രോഷിനി മാഡത്തിന്
കിട്ടി സർ. കിട്ടി സർ, കിട്ടി. പ്രസാദ് ഞാൻ ഷെയർ ചെയ്തിട്ടുണ്ട്. പ്രസാദിന്റെ അടുത്ത് അത് സ്ക്രീൻ ഷെയർ ചെയ്യാൻ പറയണേ.
Good afternoon, delegates. We will start the session in a minute. Sir, we have received the PPT. Can we start now?
Giving the introduction.
Good afternoon, everyone. It's a privilege to welcome you all to this enlightening session of our CME series Srishti on genetics and embryology. Today, we have the honor of hearing from an esteemed expert in the field, Dr. Santosh Kumar sir, who will be presenting on a highly relevant and important topic, genetic workup in a child with global developmental delay. Dr. Santosh Kumar sir holds an MD in Paediatrics along with various other prestigious diplomas in his field. He has had a distinguished career in pediatrics and genetics, having previously served as professor and head of the Department of Pediatrics at Government Medical College and SAD Hospital in Trivandrum. Currently, he is the medical superintendent and professor in the Department of Paediatrics at Azeezia Medical College. He is a prominent medical teacher with a unique combination of academic excellence and clinical acumen. Dr. Santosh Kumar sir is also a prolific author with several well-regarded books to his name, including Pediatric Clinical Examination, Treatment Guidelines for Sick Children, Pediatric ECG, and many more. These books are widely accepted by students and professionals alike and have been instrumental in guiding healthcare professionals in the field of pediatrics. Throughout his illustrious career, Dr. Santosh Kumar sir has made significant contributions to pediatric genetics and developmental disorders, and his insights are invaluable for everyone working in this field. As we delve into today's session, we will explore the critical aspects of genetic evaluations in children presenting with global developmental delays and the impact these investigations have on diagnosis and management. Without further delay, let's warmly welcome Dr. Santosh Kumar sir to guide us through this session. Sir, over to you, please.
Thank you very much. Hope I am audible, well audible.
Yes, sir, sure.
First of all, let me thank Srishti madam, and I think Sri Lakshmi is the coordinator for inviting me for this section.
Yes.
And thank you for the nice words of introduction. And one mistake is I am not a geneticist. Basically,
Yes.
of course,
Yes.
the genetic cases that we send for investigations, but basically not a trained. So with that, or this is right. This is full screen or selection. Hello, hello.
Yes, sir.
This is full screen or am I to change?
Yes, sir. It's in full screen.
Okay. So today what we are going to discuss is what a general pediatrician need to know about genetic investigation in the case of global development. So to understand that, I'll try to explain what is global developmental delay and in which situations these genetic tests are justified, because fairly expensive. Genetic tests are fairly expensive, and many a time, even after the test, you may not get a diagnosis. So we need really counsel the parents before embarking on genetic testing. And then developmental surveillance, comorbidities of global developmental delay, and how to clinically evaluate. Clinical evaluation basically regarding the need of investigation, because in this session we are concentrating on with of course special reference. And I'll add a little bit about the management, prevention. Next slide. So first we'll try to understand.
Excuse me, sir.
Ah.
Sir, you're audible, but the voice is very feeble.
Now it is audible, well audible.
Oh, yes, sir, sure.
So global developmental delay is defined as a significant delay in at least two domains, two standard deviation below the mean, in at least two developmental domains from the following. One is motor, whether it is fine or gross. Second is communication, that is speech and language. And third is cognition. And fourth is social and personal and activities of daily living. What is this cognitive? Cognitive means ability to think and reason. So that is our ability of the brain. And second thing, this is generally applied to children under 5 years of age, because we say it is a global development delay. Development occurs in a developing brain only. So beyond 5 years, it is not much. So we generally give this diagnosis of GDD for children under 5 years. So can we have a disease like a meningitis and go on for a development delay after 5 years? Yes. But then that is not really a delay. It is actually losing whatever you have been able to do. So that is why this GDD we generally restrict to under 5 years. And it should become apparent during early developmental period. That is below 5 years. That is the so-called early development period. And another uh, requirement is it is not better explained by intellectual disability, because these two things remain almost similar, intellectual disability and GDD. But if we look in closely, I think I have a slide on that. I'll come to that later. So to call it global developmental delay, it must interfere with the normal daily functioning. So if you have some delay and it is not affecting you in any way, then you don't put the term as GDD. So you can have a delay, but you are well adjusted with that. Then you generally do not apply GDD. Basically, because once you put the diagnosis of GDD, then the outlook is totally different from somebody having some delay but well adjusted to normal function. So that is why we tend to take that off this GDD. The delay should cause difficulties in academic, social, occupational, or other important areas of function. Generally, we call it GDD. And the reason I said, because the diagnosis of GDD carries with it a different connotation. So you need a lot of support, you need a lot of investigation. Suppose somebody is well adjusted with some minor delay, that is possibly. Next slide, please. Okay. Diagnosis of GDD is often perceived as preliminary, made with when a full assessment of child is, because below 5 years you can't really fully assess the child as per norms. So suppose you find a delay and you follow up and that delay gets corrected, then possibly we will take off that GDD diagnosis. So GDD diagnosis initially is a preliminary. And suppose a child with intellectual disability, at 1 year, you will possibly diagnose it as GDD. But then later when you follow up the child, you find that the child can perform his activities, he can move around, he can even talk. But only thing is his IQ is very low. So he cannot reason it well or connect things together. And, that sort of thing. So then you change the diagnosis to intellectual disability from GDD. So GDD given in the initial period for a small child is always a preliminary. So you have to reassess as the child grows. Sometimes you may be giving an early intervention so much so the child improves because of intervention. Then also you need not put the diagnosis GDD if the child has improved, because GDD carries with it some negative meaning. So as far as possible, we try to take it off in a child who is not having. Next. Children with developmental delay with coexistent psychosocial deprivation should be provided with stimulation and reassessed after about 6 months to 1 year. The point is, lack of stimulation is now a known key risk factor for poor child development. And efficacy trials have shown structured psychosocial intervention to successfully mitigate developmental deficits, and hence these children should be provided with appropriate stimulation before being labeled as GDD. So the point is, initially you will put a diagnosis of GDD, then you find that there is a lack of psychosocial deprivation. For example, a child, an orphan. Then you give him or her enough psychosocial stimulation, and the child picks up. Then you take off that GDD. That's what I said. GDD initially is a preliminary diagnosis. But unfortunately, GDD diagnosis will have to be put in a child because it is a developing, a disease of the developing. Next slide. Children whose delay in two or more domains can be explained primarily by other reasons also should not be in GDD brackets. For example, muscle disorder. The child may not be walking. The child cannot do the pincer grasp. Child cannot scribble. Basically because of the muscle disease. So initially when you see, you will think it is GDD. But then on follow-up, you will find that it is a muscle disorder and then you will revise it. Like that, visual and hearing impairment will definitely affect your development. So much so, you feel that the child is far below the expected level, and so you tend to put a diagnosis of developmental delay. But then, when you correct vision and hearing, the child will pick up. So that is why all these things you have to have a look before giving a GDD as a permanent diagnosis. Another thing is severe not mild or moderate malnutrition. Severe malnutrition actually can also lead on to GDD. The other thing is hypothyroidism. We all know hypothyroidism is something that is totally treatable. Only thing is you have to start treatment as early as possible. What they say is 2 weeks of hypothyroidism may take off 1 point in IQ. So the point is newborn screening is the answer, which actually we are doing in Kerala. Lead is not much of an issue in Kerala, but if there is environmental contamination with lead, then definitely that also should be ruled out before putting the diagnosis of GDD. Because suppose you put a diagnosis of GDD, then you will not possibly think of lead at all, and a correctable disease gets a permanent disability. That is, and many a time you try to assess the performance of children in nursery, school, and all. One of the reasons could be like the teachers are not skilled enough to manage children. So that also we'll have to take into account, and that comes into light when the child performs better at home as compared to school. So that is something that also we will have to think in terms of correctable things in GDD. Why we are thinking of all these correctable thing is because once we put a diagnosis of GDD, then we are going to have many tests, including genetic testing, which is very expensive. So we need to segregate children who may not get any benefit from these tests. So that is why we try to rule out all this. Next slide, please. Now, intellectual disability, what is it? It is actually mental retardation, but nowadays we don't call it mental retardation, we call it intellectual disability. So that is all. So intellectual disability is a deficit in intellectual, that is cognitive function. Cognitive, I explained earlier, that is your creative thinking, and adaptive function. Because for adaptive skills, you require some intellectual imagination. So that is one example would be like the last one that is mentioned, or object permanence. The play that we do with children, Oliche, Oliche, Kande, Kande, like that. So when you show an object to the child, and then അതിനെ അങ്ങ് നമ്മൾ മൂടിക്കഴിഞ്ഞാൽ you cover it with a cloth or something, for a very small child, the object no longer exists. For a child of 9 months, 10 months, the child now knows beyond this cloth there is the object still there. So that is the object permanence, and that is a cognitive thinking. because the child has got that picture of object, and child also has seen it being covered. Now the child can correlate these two things and come to the conclusion that the object is still there. So that is what is called this cognitive function. And this object permanence is one of the earlier milestones of cognitive function. And there are four stages of cognitive function: reasoning, intelligence, language. And language means communicating whatever you want to communicate. So it need not be like speech. It can even be a non-verbal communication. For example, a child who is crying while hungry is a language. Uh, and in infancy, we don't not that we don't we can't assess IQ. So we depend on DQ, development quotient. So development milestones achieved as per chart or as per age. Because for all these developmental milestones, you need good IQ, good cognition. For example, if you want to walk, it's not just that the muscle is needed. It's not just enough to have your uh, uh, pyramidal tract and brain intact. You need a cognitive brain that tells where your feet is when you are um, raising your feet, and how deep is the floor and things of that sort. So uh, the congregation of all these things together, that is actually what is meant by this cognitive or the intelligence. Next. Um, Intelligence above 70 or 75 is considered normal. 50 to 70 is considered mild retardation. 35 to 50 is considered uh, moderate. 20 to 35 is considered severe, and below 20 is considered profound. Next. That's not important in this discussion. Next. Okay. Now coming to the etiology of global development. It can be prenatal, it can be perinatal, and it can be postnatal. Prenatal can be mostly unpreventable, like genetic chromosomal disorders like Down syndrome, or a monogenic disorder. That means single gene is involved, like Fragile X syndrome in males. Multiple malformation or recognizable syndromes where a genetic abnormality may be detectable, may not be detectable. And inborn errors of metabolism, cerebral dysgenesis, and CNS malformation. Intrauterine infection, which is preventable. The other things are possibly not preventable, but intrauterine infection definitely is preventable. And that can be considered as a teratogen. Other teratogens are like toxins, alcohol, valproate, cocaine, and so on. So these are preventable things, but chromosomal things largely not preventable. But of course, by counseling and aborting unwanted fetus, it is a different difficult thing. What we are discussing is after you have conceived. So perinatal means the most important thing is hypoxic ischemic encephalopathy, causing brain damage and then global delay. Neonatal complications like bilirubin encephalopathy, where your extrapyramidal system and your cognitive brain is affected. Meningitis or encephalitis causing sleep delay, prematurity and birth. And acquired comes like hypothyroidism is the most important thing, something that we should not be missing. Now Kerala, all babies born are trained for hypothyroidism. Then brain tumor, infantile tremor syndrome, which is basically because of B12 deficiency. Very severe B12 deficiency in mother will present as ITS, infantile tremor syndrome in a baby. And very severe B12 deficiency is possible only in a very strict vegetarian mother. Because in almost all non-vegetarian, B12 is there. And in our own body, the body also synthesizes B12. not a very common thing, but still can occur. Severe psychosocial deprivation or neglect, children from orphanage and all. There, it is a correctable thing, but you will present with global development. And nutritional deficiencies, for example, iodine, vitamin B12, thiamine, even iron. Iron, in addition to your blood formation, has got a role in these things, basically because it is part of many enzymes. And lead, we have already said. Nowadays, it's not a big issue because lead pipes are not there, and the lead paints are also not there. Not a big issue, but still. And post-traumatic. Next. Okay. Now, clinical evaluation. Detail is especially consanguinity. Very important because we are discussing genetic testing. So, consanguinity is very important. Clinical examination for assessment of developmental delay, that is both by history and by actual examination. And etiological risk factors and comorbidities should be recorded as accurately as possible. Comorbidities, for example, was a baby of diabetic mother and had hypoglycemia in newborn period. So that means you have some, actually, a symptomatic hypoglycemia in a newborn has got a 50% chance of leaving permanent problems. So these are the things that you elicit from history. And recording is important because otherwise they may be blaming our health system for all these issues. Definitive diagnosis of GDD should be based on the result of standardized tests of development and ruling out situations that I have already discussed, no? Like B12 deficiency, like hypothyroidism, like emotional deprivation, things like this. Next. Yeah. What are the warning signs? In a newborn, dysmorphism, like Downs, we all know we have a typical face. So, dysmorphism means you are very, very likely to have chromosomal abnormality. Then microcephaly, major organ dysfunction. For example, you have a problem with feeding and breathing. Breathing, basically because your breathing center is not functioning properly. And feeding problem, for example, your pseudobulbar palsy, where during feeding it touches your pharynx and you sort of retch and try to vomit. Just 1 minute, I'll detach this from computer, otherwise that bell goes on for me. Okay. No, that bell will not disturb. So in the later infancy, gross motor delay and fine motor. Later infancy means fine motor delay as well. As I said, in the early period, for example, child has got to scribble. So it is not really actually more your motor system is doing it, but motor system is not the one that actually initiates and maintains that movements like scribbling. So that needs your cognitive brain. So that is why instead of IQ, you can take development quotient in a small child, because IQ you cannot formally test in a small baby. Then failure to interact with the environment or with parents. Two issues. One, it could be a visual problem, it could be a hearing problem, and more important, it could be autism. So, especially beyond 1 year, if you feel that the interaction of the child is not good enough, so you have to really screen for autism using standardized screening chart. And the importance is not that you can revert autism, but if you intervene early, you can make the child function much better. So that is why, because suppose you start the intervention at 5 years, the results are going to be very poor. So that is why you have to start the intervention somewhere around 1.5 years. And in toddlers, language delays or difficulties. That also could be one of the problems of autism, or it could be a specific learning disability. And of course, you have to make sure that the vision is known. And all these things become, I mean, accountable only if the child is given proper training. Suppose the child is not given any training and then the language not developing, that is not a um, global disease. So that is also another thing that we have to keep in mind. For example, you are testing a child with cubes. Suppose the child has never been exposed to cubes, then the child will not stack the cube. So that is the thing that we have to keep in mind. And in preschool, you have language difficulties, behavior difficulties. Right. And in school age, academic underachievement, and most of the time it is due to specific learning disability or attention deficit. Because all the others you will generally detect before 5 years. Next. Yeah, these are the comorbidities of global development delay: visual deficit, hearing impairment, epilepsy. Cerebral palsy we may not include because cerebral palsy may be associated with global development delay, but it is more of a motor disorder than a cognitive disorder. Pseudobulbar dysfunction, very, very important, because pseudobulbar is an upper motor neuron, which means the reflexes are exaggerated. The moment you touch, not you, the food touches the pharyngeal wall, you gag and vomit. So swallowing becomes nearly impossible. So that is feeding issue with pseudobulbar, which is very common with cerebral palsy. Sleep issues. These delayed children find it difficult to initiate sleep. Now, recurrent infection, that is non-neurological. Suppose the child is always lying down. You can have a postural stagnation and pneumonia, and protein energy malnutrition, and more than that, specific nutrient deficiency. For example, iron deficiency. For example, vitamin D deficiency. Then drooling. Drooling is also part of pseudobulbar dysfunction, but drooling per se can occur. And constipation and nutritional needs. The rest of the things I think we'll discuss later. Next slide. Yeah, in taking history, what are the things that you have to keep in mind? Antenatal, postnatal, and perinatal risk factors that we have already discussed to some extent. Then family history, preferably including 3-generation pedigree, because we have a genetic background in mind. And asking for consanguinity. Recurrent miscarriages, another red flag sign of genetic abnormality. Birth defects, unexplained infant deaths, common both in genetic defect and a little more common with inborn errors of metabolism. And neurological conditions, genetic conditions, etc. We take a history of, like in family. Document major milestones in all domains so that you can mark it in a graph and see whether the child is following a expected pattern. In anthropometry, the most important thing is the head circumference, and in general examination, head to toe, the most important thing is any dysmorphism and neurocutaneous stigmata. Because suppose you find a neurocutaneous stigmata, it could be a part of neurocutaneous syndromes like tuberous sclerosis, where child progressively deteriorates with its delays. And common syndromes like Down's, people like us may not miss because we are used to picking it up. For others, that is, you find a dysmorphism, but you can't fit in with a known entity. that is where you refer to a specialist. Screening neurological examination, any major neurological problem, like whether there is a motor problem, that can explain this delay. And current developmental delay, developmental level, and vision and hearing evaluation. That is the most important. Vision and hearing actually must come first. Then only we must proceed, because if these are not normal, the child will not attain any of these milestones. In addition to the above, the secondary level investigation should be like diagnosis of common genetic syndrome, common comorbid conditions, diagnosis of medical and behavioral comorbidities, screening for inborn errors of metabolism. Inborn error of metabolism has got a typical presentation. At birth, you are okay, and when you introduce the offending substance, only you get the symptoms. For example, galactosemia, unless you start milk feed, you will not have any problem. Fructose intolerance, unless fructose is introduced, you will not have any problem. So these inborn errors of metabolism, one, it will not be present immediately after birth, but after, once the dietary item is introduced, you will have problem. And second thing, as you grow up, there will be periodic exacerbations related to actually this food item, or you get some infection, and your balance goes. Tertiary level, the diagnosis of rare syndrome, that is something left to tertiary level setup of genetic specialists, because it is very difficult for our part without further investigation. Next. Approach to global developmental delay, the DQ is less than 70 in more than either two or more developmental. So what we do, we take a detailed history and examination, which we have already said. Hearing and vision screening. Screen for comorbidities. Comorbidities, we said, many comorbidities we said, like epilepsy, we said, visual disturbance, hearing, so many. Plan investigations based on clinical assessment, and early intervention is the key. So we must look for referring for early intervention if you find something problem. So most important thing is investigate for treatable causes. Treatable causes would be like we already discussed. We already discussed thyroid function test, treatable things, iron levels, B12 deficiency, biotinidase deficiency. Biotinidase is very typical, like you have either a bald or a sparse hair with a lot of scaly lesions over there, like something like seborrhea, and then intellectual retardation, and lead in a place where lead is an issue. And CPK level, for example, if it is a muscle disease, you will have CPK elevated, especially the muscle dystrophy. And then possibly you can cut down the investigation. We need not do all this. So one first step in a global development delay is focused history, and then investigate or look for treatable causes. That's what we said. Now coming to the next level, that is abnormal head size, neurological findings, or seizure. That is where you will take MRI and EEG. MRI is always preferable to CT, because the structural abnormalities are better picked up in MRI. But the problem is, for MRI, you need a half an hour or maybe 40 minutes for the child to be inside that coffin-like thing, which is frightening. So you may have to sedate the child. And when you're sedating the child, it is always important to see that the child's vitals are monitored. So not a very easy thing, MRI in a very small child. EEG is indicated if there is epilepsy or child has thrown a seizure. Otherwise, not. Now, so that is the second thing. First is investigate for treatable causes. Second is abnormal. I mean, when there is a CNS abnormality, go for MRI. Third is you have a consanguinity, positive family history, or recurrent child loss, developmental regression, episodic decompensation. Episodic decompensation is typical of inborn error of metabolism. So there you look for inborn error. And the next thing is you have no clear etiology, or you have an idea of the etiology. For example, the child looks like Down syndrome. So in that situation, you go for genetic. And once you test and reach a diagnosis, then start management. It may not be treatment always. It's a multi-disciplinary management. Next. So now coming to the investigation. Investigation should always follow a careful history, detailed examination to plan targeted testing. We should not be going on testing left and right. It must be because it is going to be very expensive. That is why. So vision and hearing screening, I stressed at least 2-3 times by now. So it should be done in all cases, even if you think the vision is normal or the hearing is normal. For example, the hearing may appear normal, but child may not be hearing the high tones. So unless you do a formal testing, you will not pick it up. So if you are not picking it up, the child will have a delayed speech development. Why? Because whatever we say, part of it only the child will be hearing. The higher tone the child will not pick up. So naturally, child's articulation will be difficult. Child will have a delayed language development. And the test not easy. We may have to adapt to child's abilities. For example, I said the high tone deafness. High tone deafness, how can you test without a formal testing? Formal testing with all these things, the child will not allow. So maybe you will see child's reaction with sound. So that sound, after ordinary sound, you will apply a high tone, just pure high tone, and see whether the child is responding or not. So you may have to adopt. Going away from the standard equipment, you may have to adopt. So that is what I wanted to emphasize there. So it's not very easy in usual setups. So that is the importance of sending the child to a setup which is having or taking care of such children. They only have this adoption of standards. Neuroimaging is recommended when specific clinical indicators are present. That is what I said. You have a CNS suspicion, definitely you can. Otherwise, no. Next. EEG is recommended when there is a seizure. Otherwise, not. The current trend of doing MRI and EEG for all is not needed because it's a waste of money and you do not get any information that will improve the child's condition. So that is biochemical and metabolic investigation should be primarily targeted towards identifying treatable conditions causing or associated with global developmental disease. So that is basically for inborn error of metabolism. Evaluation of thyroid function in all cases, whether you have a symptom of thyroid or not, all cases. In fact, in Kerala, we are now having a routine screening, newborn screening program of which thyroid function is one. The test may need to be repeated at regular intervals in suspected children. For example, Down syndrome. It can develop hypothyroidism later on. So you have to periodically check for hypothyroidism. Not that you are going to revert Down syndrome, but suppose hypothyroidism is adding on to Down syndrome, child will become even less developed compared to a pure Down syndrome. So we want to want that child to reach its potential. So that's the point. Next slide. Yeah, these are some of the other treatable conditions. One is biotinidase deficiency. I said about that hair and all, no? Seborrheic dermatitis and development. Iron and B12 deficiency must be considered and treated. Lead levels in places where it is possible. CPK is recommended in boys with motor delay. And why boys? Because many muscle disease more common. For example, Duchenne is common in boys. Appropriate genetic tests are recommended in presence of clinical suspicion of a genetic disorder or in the absence of a clear etiology. So either you have a suspicion of a genetic disorder or you have done all the tests and you are nowhere. That is also another reason for doing so. And in all males with retardation, look for Fragile X, because although we describe typical patterns and species in ear, but there are so many apparently normal retarded males who are having Fragile X. So any retarded male always look for Fragile X. A similar thing in female would be Rett syndrome. Any retarded female, especially the retardation after 1 year of age, may be having Rett syndrome. Next. Yeah, this is regarding that Rett syndrome, again in X chromosome. Fragile X is also in X chromosome. So these things are all causing mental retardation. Sequence variations and or copy number variation, either deletion or duplication within this MECP2 gene will be detected with almost total sensitivity by new generation or next generation sequence. Next slide. So going on with our approach, detailed history we have already said, examination, failure to thrive, microcephaly, macrocephaly, dysmorphism, malformations, behavior phenotypes like hyperactivity and all, and neurological examination and organometry. If it is fitting with a specific chromosome anomaly, do the test. For example, the child looks like Down syndrome. Do the karyotype. And if conventional karyotype doesn't deal, then we can go to other tests that we will come to. If it is fitting with a specific gene disorder like Fragile X or Rett syndrome, go for specific tests, targeted PCIs. That also will. But many a time, nothing, you will find a child with global developmental delay, but you do not find dysmorphism, you do not find anything fitting with a well described syndrome. So, there, chromosomal microarray, CMA is the test of choice. Actually, you can go for next generation sequencing or exome sequencing, whole exome sequencing, but both are expensive as compared to CMA. So, as a first step, go for CMA. But then the question is, suppose CMA fails, then you will have to go for NGS, next generation sequence. That makes it double expense. So that is why we have to counsel parents. For example, CMA, if we can do it for 10,000, whole exome sequencing will be 18,000 plus. So actually, if something detectable by CMA, then do CMA and you save some 10,000. But the problem is sometimes you may not come out with anything, and you may have to proceed to exome sequencing, which means another 20,000. So that makes it 30,000 extra expense. So these things we have to tell or discuss with parent first, and then only take a decision. Otherwise, they are going to blame us. Blame us means nowadays the fashion is we are all trying to extract money from them. So that we have to possibly in anticipation. Next. Now, just about actually, I'm not a geneticist, so I know only the superficially this testing. We send for tests, we get the results. We do not know how exactly these tests are being done because we have a genetic specialist in a city, so we are not concentrating. One, karyotyping. Karyotyping is something that has been there for decades, for generations. This is you stain the um, chromosome. Genes are stained during cell division. You arrest cell division at the metaphase or prometaphase when the chromosomes are most advanced. You arrest cell division with a drug like colchicine, and then you stain. And after staining, then you can number the chromosome and arrange the chromosome. Then you can detect aneuploidy, that is abnormal number of cells. I mean, abnormal number of chromosomes cells. Some extra chromosome may be there, some missing chromosome. So suppose it is 45 and XO, then it is Turner. So similarly, the other use of karyotyping is very cheap. So karyotyping, one what you can detect is things like Down syndrome, where things are obvious. So one chromosome is extra, one part of chromosome is extra, like that. Or one is missing. Second, you can determine the sex of the individual because we know whether it is XX or XY. Third is translocations. Unbalanced translocation is easier to detect because it is easy to pick up because of the difference in size because it is unbalanced. There is either loss or gain of genetic. Balanced translocation, whatever you have lost from one chromosome is there in another chromosome. That also can be detected in karyotyping, but it needs to be big deletions because the resolution is about 5 MB. So if it is a deletion that is less than 5 MB, like 1 MB or 500 KB, that will be totally missed. Large deletion, duplication, inversion over 5 MB can be detected by karyotyping. So karyotyping basically you can apply in Down syndrome, Klinefelter syndrome, Williams syndrome, things like that, where you view under the microscope and found the chromosome and any abnormality in the chromosome, like one is longer, one is shorter. There is something called spectral karyotyping, which nowadays we are not doing. Historical importance only because here you chromosomes comes in. I mean, takes up different colors. So much so, if one part of chromosome is getting attached to some other part of another chromosome, it is easy to detect. So this is generally for complex translocations involving multiple chromosome, and you have the option of karyotyping only and not anything else. Then maybe this is an option, but nowadays we have other options. So people are simply not using this thing, so you can forget about it. The next thing is the triplet repeat primed PCR. Triplet primed PCR is basically for fragile eggs, where the CGG repeats beyond a limit make you affected with mental subnormal. So in X chromosome, CGG repeats up to about 45 is considered normal. 45 and between 45 and 55 you consider as indeterminate, and 55 to 200 it is the so-called premutation. This is I'm talking about the mother. So mother is having a copy number of between say 55 to 200. It is a premutation. It will get into the child, and in the child, if it is going above 180 or 200, then the child is an affected child. And this the child gets almost always from the mother. It is never de novo. Almost never. Suppose the mother has 55 repeats. That the male child, it can occur only in male child because it is carried in X chromosome and mother gives X chromosome to male child. And there is no second X chromosome in a male. So, male, suppose mother has got 55 repeats and the male child can have 55 repeats or more than 55, but never less. So, the number of repeats the mother has got will be transmitted to the male child without doubt. So, if it is 55, male also will have 55 or more. Suppose it is 100, the male child will have 100 or more, but never less. But it can be more. So, that is why after a few generations, it increases. See this 55, next generation it becomes say 65, next generation it becomes 100. Like that, after a few generations, affected child comes. So, that is the point that I want to discuss. Next. This is the most common test that is applied, chromosomal microarray, CMA. Micro deletion is a small deletion of genetic material from chromosome that's too small to be seen by microscope carrier. So, it's a small deletion. The chromosome analysis or the karyotyping comes as normal. Why? Because the deletion is too small to be observed in your microscope. So, for that, we use our PCR technique where it's a sort of chip or a solid medium coated with thousands, 2,000, or even millions of known DNA. So these are fluorescent tags, and to which the RNA or DNA sample is added. So these things go and bind to specific fragments, and these fluorescents are counted by machine because manually it is not possible. Too many. So the machine will count. So this can detect deletions and duplications, but can miss balanced translocation, but unbalanced and small deletions, duplications will be, and detects copy number variation. There the problem is, especially in autism, whenever you do a genetic test in autism, in as much as 20%, you will have an abnormal result, and the abnormal result is copy number variation. So we do not know whether it is actually causing autism or not, because this copy number variation is not shown to cause any problem. So when the copy number variation comes, you use your common sense. Like this copy number variation involves a gene which is known to cause a disease. Then you take it as a, or variation is too big. So you just assume that some of the important genes may get entangled within it. So that is the problem with the copy number variation. Copy number variation, we can just tell the parent that we have detected this copy number variation. We do not know whether it is causing the disease or not. So in future, research may show that such a copy number variation can cause such a disease. So in future may help in diagnosis, but not really now. So that is the sort of counseling that. Next one. Fish or the fluorescent in situ hybridization. Fish uses fluorescent labeled DNA fragments that bind to specific sequence in chromosome. That we all know. No? Complementary sequence, these fragments go and bind. Can detect specific microdeletions if we guess where it is. Got the point? We are adding a fluorescent labeled DNA that is complementary to an area that we suspect is having a problem. So unless we know which area is likely to have a problem, we can't have a fish probe that is complementary to that area. So when we know the area, for example, clinically it is Williams, then you do a fish and it comes as negative. So that means it is not Williams. So you need not spend much money. So fish can be used when you know a specific sequence on the chromosome is likely to be a problem. Then you can use specific fish for that reason. Another thing is if a proband deletion, that is a affected child deletion, is known, next pregnancy you need not do the whole genome sequencing and that. Just specific fish for that deletion. That will tell whether that particular problem is there in this next pregnancy or not. So that is the this is the present in thing, that is next generation sequencing, which is fairly expensive, 20,000 plus, depending on how much sequencing you need. It can be used to profile the entire genome and identify disease associated variants. It will pick up all the variants, but as of now, we do not know what are the abnormalities that are causing what disease. Only some of the diseases we have already correlated with the genetic variants. Whole exome sequencing, these are actually safe. This NGS, next generation sequencing, and exome sequencing are more or less same. Only thing is, in exome sequencing, we sequence the protein coding regions of genome only, because generally it is the abnormal protein that is causing the problem. So most of the diseases can be picked up with this. So it is a more focused, whole exome sequencing means it is an NGS only, but it's a more focused analysis of the coding regions of the DNA, which is more likely to harbor disease-causing mutations, which means you can do it at a lower cost than whole genome sequencing. So that is the only advantage. The next generation sequencing, you will also pick it up without doubt, but there you pick up so many other things also, which is not necessary. So exome sequencing, it's more focused towards the possible disease causing region. So that is the difference. Next. This is again not nowadays much used. Sanger sequencing is determining the DNA basis in a specific region. Here also we need to know that one specific region of the genome is causing the problem. Generally we can use it. It detects single nucleotide variation. Single nucleotide variation it will pick up. So that way it is a very good one. And most useful to check whether the child's variations are there in parents. Yeah, that is, you have the child's variation. So whether that same variation is present in the parent, this Sanger sequencing is very good. Sanger method only sequences a single DNA fragment at a time, but NGS also will pick it up. But only thing is, NGS will pick up millions of other fragments, which makes it more confusing. Because if a child is having one particular disease, what we want to know is that particular genetic abnormality is there in the mother or not, to transmit to the next child. So there, why do we want to do NGS and sequence millions of fragments? So that is why you go for Sanger fish. Next. Now going on to the management, because madam said about a 2-hour engagement, this genetic test alone will not cover 2 hours. So that's why I am discussing global development delay as a whole. Management, treatment, and support for individuals with development disabilities and mental delay vary depending on individual needs and specific conditions. So naturally, it is a multidisciplinary team. Next. Next, please. Okay. Early identification, intervention, and support services are essential in improving individuals' outcome, helping them to lead fulfilling lives. The point is, you are not going to make them normal. We are going to make them reach their full potential that is possible for that particular child. For example, a Down child cannot reach the full potential of a normal child. Down child can reach only the full potential of a Down child. Suppose he has got a hypothyroidism, he cannot reach that potential. So that is what we are trying to do. All the morbid conditions will be taken care of, and then for the global developmental delay, we'll start intervention very early, because it is the developing brain that will pick up things. The fully developed brain will not pick up all these things. So, intervention early is the key word. And early intervention for infants at risk of development delay should start in neonatal nursery itself. For example, a very preterm baby, 28 weeks, that we know is prone for a developmental delay. So, stimulation will start right from newborn nursery itself. And what is this early stimulation? That is another topic, so I will not go into that. Only thing is, we must start it right from nursery life. And potentially treatable causes should be addressed. Next. And then these children should be on a development survey. Actually, all children must be on a development surveillance, but all children need not have any detailed development. You ask history regarding the developmental milestones achieved when they come for immunizations. So, immunization visits can be used for obtaining information on that. For high-risk infants, in addition to surveillance, developmental screening should be done. That is, you use some easy to use charts. There are difficult to use charts which are used by professionals, but we doctors generally use the screening charts. And here, in addition to history, you try to plot it in a chart and see whether the development is appropriate or not. I'll show a chart. And children diagnosed as global development delay should be screened for autism at 18 months, because autistic child at 1 year will present only as a developmental delay. So whether it is autism or not, minimum you need the child to be 1.5 years to detect. If it is not conclusive, maybe you will repeat the test at 2 years and 3 years. This is easy to use development screening chart that we use. This is a Trivandrum development screening chart, where suppose the child is 10 months, you place a scale over here. So this scale will, there are these bars that are stopping before 10 months. These things must be achieved. If it is not achieved, then there is a delay. Suppose the child is not transferring objects at 10 months, it is a delay. And suppose the child is not standing up by holding on to furniture at 10 months, well, it is okay. Maybe it will take 1 more month to achieve it, because at 11 months, but most of the children will have achieved it by 10 months. So it is a red flag sign, but not yet time to say that it is a delay. Next. Treatment options, there are many, like therapy, speech therapy, occupational therapy. Occupational therapy means you make them capable of doing day-to-day activities, like activities of daily living. Behavior therapy, and help individuals to acquire skills and improve their overall function. Medication in some cases will require, especially in ADHD, mood disorders and all. We may require medications. Of course, all systems of medicine will have their own medications, but we will use some medication to stabilize their mood. And in addition to medication, there are other modalities of management of mood disorders, but doesn't work in a very small child, because you need cooperation from the person involved for these non-drug medications or non-drug intervention to act. That is not possible in a child. So in a child, generally you require education and individualized plans, specialized education program, because their needs are unique. Each and every child will have difficulties that are unique to that child. So the standard educational programs need to be uh, specialized and individualized. Not a very easy thing to do, but and it is an expensive thing to do also, because those who are taking care of autism knows how expensive it is, because so many people are involved and so many individualized programs are needed. And that is why it becomes very expensive. Supportive services like counseling, support group is very important, because the parents of children affected with the similar disorder, so they know what to expect and what improvement to expect and where exactly can we have a better management like that. Early intervention, I said, that is the most important thing, whether it is autism, intellectual disability, or global delay. Your brain is, whatever brain that is left intact, that is most receptive for learning and development. So that is the importance of starting in early intervention. Next. Children with global developmental delay should receive preschool education services in the least restrictive environment that is possible and appropriate to address their needs. In fact, nursery education, that is preschool education, must not be restrictive even in small normal children. And it is more important for children with difficulties. So again, it becomes difficult, because suppose a class has got 20, 30 children. It's difficult to individualize care. So again, it is going to be expensive if we go for individualized management. Children with development delays should receive routine healthcare interventions like any other child, like immunization, nutrition intervention, etc. Early intervention should be initiated soon after delay is recognized, instead of waiting. That is one mistake that we always do. We refer the child to so many places, and it takes a lot of time to stamp a diagnosis of either intellectual delay or global development delay or a specific learning disability. And then you start intervening. No. Whatever be the diagnosis, you start intervening. Because you don't need a diagnosis to intervene. Suppose the child is finding it difficult to stand, support the child to stand. You need not wait for a diagnosis to give that support like that. For example, a delayed speech. You sit with the child, go on repeating like that. You need not wait for a diagnosis whether it is autism or not. So that is what is meant by early intervention. So whatever you do, that whatever little brain that's intact will pick up. So, and because in a very small child, these brains are not specialized, which means one area will do only this thing. That is not there. So areas that are not destined to speech or any cognition can take up that function also. Only thing is you uh, make it a necessity for the brain to do it by constant stimulation of that particular area. Other diseases, for example, seizures. Suppose somebody is destined to have seizure, he'll have seizure with you. So it is a febrile seizure. It can be managed just like any other intermittent prophylaxis for recurrence. And EEG generally we do not do for febrile seizure, but in this case we may do it, because it may not be febrile seizure, it can be a seizure. Next. While some accommodations and modifications may be necessary, individuals with developmental disability and mental delay can engage in various forms of physical activity and games, but you need accommodations and modifications. For example, you play a basketball. This fellow may be sitting in a wheelchair and do the basketball, and somebody will have to uh, pick the ball and give it to him. He cannot really run after the ball. So similarly, modifications are made, but still engage them in physical activity. And regular physical activity not only improves physical fitness, it promotes social interaction, enhances cognitive function, and boosts overall well-being. So that is more important than just physical fitness. Next. Now, the physical activity, as far as this individuals with developmental delay is concerned, is physical activity for its own sake. It is not for a competition. It's not for winning. It is not for achieving any specific goal either. It is for enjoyment. It is for participation. It is for social well-being. So that is the point. We should not really focus on winning and losing. That is not an issue at all. Even we promote games or sports for children with needs. Next. Yeah, these are all adaptive sports, like I said, how to adapt sports. Swimming is a very good exercise because even people with motor delay or muscle weakness, water buoyancy helps. So in water, they can do a few exercises which they cannot do in outer water. So swimming is a very good one, and dancing and movement therapy, because dance means in a group, not as an individual. In a group, it enhances the happiness component of the child. This yoga and mindfulness is possible only in a limited number of people because it involves a lot of concentration. So you may be doing when the child can possibly watch and child can imitate, but not very possible in a child with delay. Adaptive cycling, that is, you adapt the child for use of this child. Then, like dancing, you can possibly go for martial arts, recreational games, and so on. Next. Prevention examples of primary program to prevent intellectual disability and global development delay. One is the public awareness on the effects of, say, for example, alcohol or other drugs abuse, because alcohol will produce a fetal alcohol syndrome with so many problems, including heart disease. So these are the things that must go into public. The most common preventable cause of intellectual disability in Western world is fetal alcohol exposure. We are all copying West in so many things, so not very far away when we start getting such children. Even now, we have occasionally we get. So increasing the public awareness is one. Second is the encouraging safe sexual practices, preventing because teen pregnancy means you are going to end up with premature baby, or you may try to abort it and you fail and you deliver the baby. So the problems are still big ones. So promoting early prenatal care with focus on preventive programs and vaccination of girls. For example, rubella vaccination. Suppose you get rubella, not just heart disease or cataract, your whole cognition is gone. So girls should focus on getting MMR vaccine, because girls of reproductive age of today may not have got MMR when they were children, because at that time it was not part of our schedule. Next. Preventing traumatic, very important, especially the nowadays we are seeing traffic injury and causing brain damage. So, like this one, helmet, like seat belt, and how to use roads, somehow prevent from all the avoidable injuries. Especially in a child with retardation, you may have to use the restraints. For example, bed may have to have railings to prevent the child from falling. Now, the other thing is preventing poison, especially at home. And example would be anti-diabetic drug. Anti-diabetic drug, if the baby take, it will go on for a hypoglycemia. And the symptomatic hypoglycemia, I told earlier, 50% will have a permanent problem in the brain. So that's a preventable. So that is why. Next. Implementing immunization programs to reduce intellectual disability caused by, say, encephalitis, meningitis. Encephalitis and many encephalitis, Japanese encephalitis, we are actually now giving vaccine in Trivandrum and Malapi district. Meningitis, of course, we know about the vaccines of pneumococcus, influenza, and so on. So all these vaccines, prevention is always better than cure because there is no cure. Once your brain is damaged, there is no cure. Only thing is you do an early intervention, train the remaining part of the brain to do the job that the damaged brain was doing initially. And that is possible only when you start early, not in a, for example, in an adult with stroke, generally do not pick up what they have lost. But in a child, what the child has lost, generally they pick up because the rest of the normal brain can take up the function of the damaged. So that is possible only in a developing brain, and that's the importance of starting intervention. Early detection of disorders can. Counseling is disclosing the diagnosis. It's a very, very painful procedure, but somehow we will have to do it. And the parents' adaptation to that diagnosis or acceptance of that diagnosis, that in a very large extent, it depends on the way you convey it. So it all depends on the rapport between the doctor and the patient. And that's why the primary care doctor must be the one who is disclosing. A very specialist who is seeing the child for the first time, if he discloses the diagnosis, it becomes difficult for the parent to accept and ask questions. But primary doctor, they are closer, so they'll ask questions, clear doubts. It is important to communicate the diagnosis to the family clearly and directly in a compassionate manner, emphasizing whatever strength the child has got. For example, Down syndrome. The strength is that most of these Down syndrome children, they perform better than what their IQ indicates. That is one strong point we can tell them. And another thing is, many of these retarded children, they are causing problems to the other children. They are fighting and all. But Down syndrome is very friendly. So that is another strength. So for each of the diagnosis, we must tell the strength or the plus points, if any, so that the parents can have some solace. Next. Counseling regarding investigation is important. Earlier I said, no, suppose you advise chromosomal microarray because it is 10,000 rupees less than next generation sequence. But suppose CMA did not detect anything, then you will have to go for NST. So it becomes 30,000. So about 20,000 more than what is expected. So these are the things we must discuss before investigation, not after. So that they will, some of parents may say, okay, then we will not go for CMA. We'll straight away go for next generation sequencing. Then it is fine. So we have to take into account their financial status and their decision. As etiology of GTD is complex, patient may need to undergo several tests before conclusive diagnosis. And the family needs to be counseled that despite undergoing all the possible tests, the diagnosis may still be elusive. So that is painful truth. Next. And counseling, of course. Pre-test counseling, that is always there in all genetic tests. Pre-test will tell what is to be expected. Suppose the test is done, what is the benefit for this child for future pregnancy, etc. Many a time, after the test, what happens is you will find a genetic variant of uncertain significance. You know it is not normal, but you know it is not associated with any known disease. So you do not know what to counsel because this child is not normal. This child has got a delay, and you find something that is abnormal. But this abnormality, as far as your knowledge goes, is not related to this particular disease. So that becomes a confusing situation. So in such situations, it is best that we leave the counseling to the genetic specialists so that they'll give uh, the possibilities of this much percentage, this may have this much percentage, this may have that. That sort of counseling they can. Next slide. Regular follow-up and targeting all developmental domains and associate comorbidities is the first thing to be addressed. So that is half the job done. And then target all the developmental domains and try to reach whatever is the optimum that is possible for that particular. And the team of experts, there are so many experts, including pediatrician, neurologist, audiologist, developmental pediatrician, then occupational therapist, physiotherapist. But talking to the parent, that should be done by one person. And that is best done by the primary care doctor, whether he is a pediatrician or even a general. He can get the information from all the specialists and then he conveys. When he conveys, it is more acceptable to the parent because there is some connection between these two people. Next. These are the usual mimics. One is the intellectual disability. Intellectual disability, I told you, it is actually mental retardation only, a new name. Intellectual disability need not have global developmental delay. It can have an intellectual delay, but need not be a global. And the autism is another problem of social interaction and communication. Again, there is no global developmental delay. The child can have a normal motor, normal fine motor. He can talk. Only thing is, what he is talking is nonsense, not appropriate for the situation. No, he may be talking something, but that is not the answer to the question that you have asked. So that way. So it is autism is a specific disorder, but it is not a global development. Attention deficit hyperactive disorder, again, it is affecting attention. That is in Malayalam we say viru. So you do not concentrate on a particular area for long. Simply move to the next, then move to the next like that. And impulsiveness. ഒന്ന് പറഞ്ഞ് രണ്ടിന് ചാടുന്ന ആ ഒരു impulsiveness. Then the specific learning disabilities. Specific learning disabilities is like dyslexia, where you have difficulty in reading. That is word blindness. That is, you actually, how speech sounds relate to the letters or words. Whatever you talk, how it is relating to the written word, that is not deciphered quick enough. So you have a stuttering problem, and you have confusion like mirror image confusion, D for B. Dysgraphia means written language deciphering problem, and dyscalculia is number. All these things are actually part of dyslexia or rather specific learning. Okay, so that's all I have to offer. I went on a little extra outside genetic testing because genetic testing basically is a 15 minutes talk. So thank you very much. Any questions?
Thank you, sir. Thank you so much. So can we move on to the query session? Delegates, if you have a question, please feel free to type it in the chat box or use the raise hand feature to ask directly. Sir, there is
I
a
thought
doubt from
only a
Dr.
few.
Aisha.
Excuse me.
Sir, yes, please.
I thought only some 10 PGs will be there, but it is almost 100. Yeah, he said only postgraduates are attending, so I thought it will be minimum number.
Sir, there's a doubt by Dr. Aishwarya. The question is how to approach a case with global developmental delay with antenatal, perinatal, or postnatally uneventful MRI that is having normal findings, and on examination, if spasticity is present.
Uh, Global development delay with spasticity most likely is due to cerebral palsy. And cerebral palsy, for example, the commonest cerebral palsy is diplegia, which is common in preterm. So diplegia, although initially presents as global developmental delay, as you follow up, it becomes more of a motor delay than other delay. They generally do not have seizure. They generally do not have intellectual retardation. So they will be diplegic. They will have a difficulty in walking, scissoring and all. But they have a normal, near normal brain and near normal function. So that particular child, you examine and see whether it is a cerebral palsy or not. Cerebral palsy means you have UMN signs, bilateral, either predominantly lower limb or all the four. If all the four is involved, it is more likely that you will have global developmental. In which case, you may go in for a MRI. MRI in a quadriplegic CP cannot be normal. But since here MRI is normal and spasticity, one is cerebral palsy and cerebral palsy mimic. For example, uh, glutaric aciduria type 1, which is a enzyme defect but presents something like cerebral palsy. So you look for that particular enzyme problem and see whether it is that. So genetic testing, if you in this scenario, if you want genetic testing, the best thing is go for next generation sequence, which is expensive, but all the other things are unlikely to give a result. See, a karyotype is going to give you a result only if there is some dysmorphism. And microarray in non-deletions microarray or a fish, yes. But you are in an unknown area, you need scan all the genes, whole genome sequence. There you need NSD. But when you are counseling on NSD, tell them that you may end up finding nothing. Any more?
Sir, there's a question by Dr. Arsha. Sir, sometimes GDD is seen as a comorbid condition to other neurodevelopmental disorders like ASD. Do they share any genetic risk factors?
Regarding that, ASD generally we pick up as a GDD, and later on detailed evaluation, we will see that this fellow can walk, can scribble. Only thing is he is not scribbling when you are asking. because he is considering you as an inanimate object, not as a parent and all. So he will go on doing whatever he wants. So that is not a global development relay, that is ASD only. Now, whether ASD can be associated with GDD, actually it is the other way around. GDD patients can have ASD manifestation. And what investigation you do, uh, what investigation you do is uh, actually microarray must be enough for GDD. I mean, not GDD, those with ASD manifestation. Chromosomal microarray will show uh, copy number variations. Copy number variation, whether that is causing this ASD, we do not know. As of now, we do not know which copy number variation causes ASD and all. So after the investigation, what we can tell them is there is some abnormality that is found in this child, that is a difference from what is present in normal child. So we do not know whether that is the one that is causing the problem, but there is something abnormal seen, and nothing actually can be done to revert it.
Thank you, sir. Next question is by Dr. Anju. Uh, what are the primary limitations of chromosomal microarray analysis in detecting structural variations, and how these advancements in CMA technology address these limitations?
Actually, CMA technology will not advance now. CMA technology will give way to NGS only. Why CMA is still relevant is it is almost half the expense. So that is for example, uh, next generation sequencing 20,000 plus, the other one will be 10,000 plus. So because of that cost advantage, this CMA will remain for some more time. But after that, I think next generation sequencing will take over. NSG, the problem is so many things will be picked up. So unless we know which are the significant things, you will end up with data that is difficult to analyze. Microarray, if you actually know the areas that you have suspicion, then it is easier to pick up because it will not give as much data as NSG. But if you know the area that is suspicious, then actually you don't need a microarray even. You can go for a specific fish or Sanger sequence.
Thank you for your answer, sir. Next question is by Dr. Arya. So, when should a child with GDD be screened for epilepsy even if no seizure is observed?
Uh, that's a very, very, very individualistic, I would say. For example, I have a child with tuberous sclerosis now. Tuberous sclerosis, we all know, will have skin and CNS manifestation. If you take a CT, you will have that candle drop, CT or MRI candle drop, you will find. You will definitely have seizure in due course of time, if not today. So that child, I am not investigating. Thing is, suppose I investigate and find that there is something wrong in CNS and this child is going to develop seizure and going to develop mental retardation. Why should they know in advance? Let them be happy for some time. Once the seizure develops, then only we will look for seizure and treat for seizure. Because suppose you pick it up, seizure probability, you pick it up before seizure occurs, what are you going to do? You are not going to give anticonvulsants. So, you should not actually know things in advance if you cannot intervene. Suppose we now in advance know that, suppose I in advance know that I am going to die in 3 days. Then my 3-day life is gone, totally wasted. So that we should not really go in and probe. Unless symptom comes, don't go in. That is my way of thinking.
Thank you, sir. Thank you for the answer. So next question is by Dr. Arati. How early can we do a thyroid function test in newborn?
Okay. Thyroid function, actually, you can either do in cord blood or on day 3. Why day 3 is basically because this delivery process is such a complicated, stressful event that the TSH will go up. So you will find a TSH value of 15, 20, etc. That will be confusing. So then you will be thinking whether it is hypothyroidism or whether it is going to be a borderline value. So either before this delivery process causes a TSH surge, that is cord blood, or day 3. Day 3, we are now in government sector, we are, and even now I am in private. In private sector also, we are routinely screening thyroid for all newborns because it is a heel prick test. You need only filter paper blood. So, I mean, in private it's a little bit expensive, but in government it is totally free. So you should always screen for thyroid.
Thank you,
How
sir.
early means either cord blood or
Thank you, sir. So next question is by Dr. Prasad. So what is the significance of parenting, nutritional factors, and other socio-environmental factors in GDD?
social environmental factors is best studied in orphans. So there adopts and gives the normal family stimulation. They pick up like anything. So once you find psychosocial deprivation, don't put a diagnosis of GDD immediately. Is the present thinking. You'll wait for about 6 months to 1 year before putting that diagnosis. So now regarding whether parenting, well, um, it has got an effect, but how much we do not know. It need not be parent also. Right now, mostly it is not really parenting; it is grandparenting. That is actually, um, as long as grandparents are there, the so-called parenting is not very important. I mean, parenting is given by grandparents. You need somebody. So, if there is nobody, then it becomes something like an orphan.
So one more question by Dr. Asha. So how can we precisely differentiate between cognitive impairment seen in ID and cognitive
Any
impairments
more?
of GDD in clinics?
Can you repeat that? I got only
Oh,
half.
yes, sir. Yes, sir, sure. So, how can we precisely differentiate between cognitive impairments seen in ID and cognitive impairments of GDD in clinics?
Okay. We can detect cognitive impairment. Whether it is GDD or simply intellectual disability is something that we have to decide. Uh, Earlier, for example, in infancy, uh, intellectual disability will appear like GDD only because you need that even for your motor achievements. After some time, then you will know that child is walking, child is talking, but he cannot assimilate information. That is, you give an instruction, the child need assimilate it and carry out. That is missing. So that is intellectual disability. So cognitive, that is reasoning and combining various modalities to do a task. That is what is required in cognition. So that cognition, uh, cognitive disability, we can diagnose either in intellectual disability or GD. But whether it is GDD or intellectual disability is not determined by the way the cognitive difference or cognitive disability manifests. It is same in both. Whether it is cognition. So the answer to the question is there is no difference in cognitive disability of a child with GDD and ID. Both have got cognitive disability of varying degrees. Whether it belongs to this category or that category depends on other factors. For example, in GDD, we said 2 or more areas of delay, which may not be there in ID.
Thank you, sir. Any more questions, delegates?
Actually, I am surprised by the attendance. Yesterday, I had a Zoom for Tamil Nadu postgraduate students. I was expecting a lot of students, but we had just 40 plus 42, 43, all of Tamil Nadu.
It is seeing that
Anyway,
if your
thank you for
presentation,
excuse me.
like seeing that you are the presenter, it's pulling a lot of audience.
Not. Maybe your program is pulling a lot of, because I am coming the first time in this audience, and Madam was giving me a topic that is not my area.
In our department, we are following your text basically, sir. So,
Oh, thank you.
PG, sir.
Thank you, sir. Thank you so much for that truly insightful and engaging presentation. Your expertise and deep understanding of the topic, especially in the context of global developmental delay, have undoubtedly provided us with valuable knowledge. We are grateful for the time and effort you put into sharing your experience with us today. And to all the attendees, thank you for joining this enriching session and for your active participation in the Q&A. We hope you find it as informative and thought-provoking as we did. We look forward to seeing you at the next CME session. And the next session is the part 3 of embryology by Dr. Geeta Jayachandran at 6 p.m. today. Thank you. Have a wonderful day ahead. Thank you, sir. Thank you so much.